Next, I'd like to welcome Ms Amy Legg. She'll be talking to us today on pharmacogenomic-optimised dosing of voriconazole. Amy Legg, I'm sure, is a stranger to no one in this audience, but she's an experienced clinical pharmacist in infectious diseases and antimicrobial stewardship. Her research interests are varied and include urinary biomarkers for AKI, nephrotoxicity of anti-staphylococcal antibiotics, antimicrobial therapeutic drug monitoring to ensure efficacy and safety, and uptake and efficacy of the hepatitis C medications. Amy is currently undertaking a PhD aiming to better understand renal toxicity of combination antibiotic therapy for Staphylococcus aureus bacteremia. Welcome, Amy.
Thanks so much. Thanks to the organisers for having me. And I guess the first question is, why are we not talking about staph? But I am very honoured today to give a talk about my second favourite drug, starting with V, which is voriconazole. And just have to pay tribute to the previous talk, which was phenomenal overview of all antifungals. And now I'm going to talk about one very specific thing about one antifungal. So thank you for taking the heavy lifting of the antifungal presentations today, Canpy. So yeah, I'm a pharmacist at the Royal Brisbane, and I do a little bit of work at UQCCR as well. So I think I've started this talk with maybe a bit too low a pitch, so I'm going to skip through the first couple of slides. I think everyone in this room is aware that patients with hematological malignancies can be at risk of invasive fungal infections. Sure. This was just a nice slide, again, reiterating the previous points that we've heard about the seriousness of getting an invasive fungal infection in the setting of immunocompromise. I've really just highlighted the table here by Professor David Denning in the Lancet ID paper last year, looking at invasive aspergillosis in some of the hematological malignancies with a treated mortality rate of almost 50%, and of course those very high untreated mortalities. And similarly, another infection that we can see in some of our patients with hematologic malignancies is the Candida bloodstream infections, with a treated mortality of still 35%, a huge range there of 8.7%, which was in kids, up to 77.3%, which was in a Brazilian ICU cohort study of mortality of patients with Candida bloodstream infections. And only about 10% of those patients had a hematological malignancy. The vast majority actually had type 2 diabetes. Okay, and again, just to say, when we think of our antifungal drugs, we're traditionally thinking about molds and yeast. Posaconazole has really taken over the game, I think, in terms of prophylaxis. But if we're treating invasive aspergillosis or there's a reason not to use posaconazole, we still do use voriconazole, which is why the pharmacogenomic-based dosing, I think, is still of interest. And if we don't need to worry about molds and lower risk patients just need to cover yeast, obviously fluconazole still gets a Guernsey. Now, getting into the nitty-gritty about voriconazole, it's similarly to a lot of the mechanism of actions that we just saw in the previous talk. It's another one that's acting on cell walls. It's decreasing the growth of the fungus and then causing cell death. Interestingly, voriconazole and fluconazole have extremely similar sort of background structures, but you can see the additional fluoride ion on the voriconazole, meaning that voriconazole has got those 3 fluoride ions. So whenever it's administered, you do get a big fluoride load. Which is just a toxicity to think about independently of concentration, because actually when you have low voriconazole concentrations, you might be giving big voriconazole doses, which means you're giving a lot of fluoride. So it's just one toxicity that sort of is sometimes inversely proportional to concentration. Again, as we've heard with the other antifungals, voriconazole is tricky. It has got a broad spectrum of activity. I've put here that it's got nonlinear pharmacokinetics. I'm very conscious that I'm standing in the Queensland Children's Hospital, and actually kids have linear pharmacokinetics of voriconazole to much higher doses than what adults do, probably because their livers are better and they have more first-pass metabolism. Voriconazole has heaps of drug interactions, significant toxicity, and requires a loading dose. So really, to balance effectiveness and toxicity, we use therapeutic drug monitoring. That's just a list of all the toxicities there. So I just wanted to go through as to sort of solidify in our minds what our targets are and how pharmacogenomics can help us get to our targets quicker. So in terms of a lower limit of efficacy or effectiveness outside of the clinical trial setting, there was a 2016 systematic review that looked at all the different studies that had threshold toxicities, which is going to be very hard for you to see, and was able to conclude that a trough concentration above 1 milligram per litre is the most predictive of successful outcome. A lot of the studies really used 1 or 2, and the Australian consensus guidelines now do suggest thinking about aiming for above 2 if you've got a heavy load or CNS infection to maximize your chance of penetrating to the site of infection. And then in terms of toxicity, there are some nice relationships between voriconazole concentration and toxicity. We know that there's one of the most reliable findings is the neurotoxic ADRs. So many studies have found this link between voriconazole concentrations with trough concentrations about 4, 4.5, 5, and 5.5, all being associated with the serious neurotoxic ADRs. Hepatotoxicity is probably the second most commonly studied, and although it's less reliably linked to voriconazole concentrations, it has still been found to be linked to voriconazole concentrations, probably again with concentrations above about 4 to 6. And the transient visual adverse effects, blurred vision, altered visual perception, that seems to really start as soon as you increase your voriconazole concentration above 0, but then it linearly increases as the dose increases or exposure increases. So putting all this together, our floor, so our concentration that we want to be above was about 1 to 2, and we want to keep it below 5 to 6. So knowing that we have this therapeutic range that we're trying to hit, the big problem with voriconazole is that a standard dose just really unreliably gets you into that therapeutic range at the right time. And one of the main reasons for this is the incredibly complicated, it's probably not that complicated considering we've just heard talks about HLH. So the, mildly complicated metabolic profile of voriconazole, where CYP2C19 is responsible for 2 of the arms of voriconazole metabolism. It's way out of the body, turning it into a hydroxy metabolite and also doing some oxidization. And what we know about the CYP2C19 the CYP2C19 genotypes is that they're not standard in all people. So we can have these different genotypes if you're genotypically looking at it, and you can look from the different alleles that are present whether a patient is going to be an ultra-rapid metabolizer. So an ultra-rapid metabolizer is star 1717, which is 2 increased function alleles. A rapid metabolizer is something like a star 1, star 17, so 1 normal functioning allele and 1 increased functioning allele. A normal metabolizer star 1, 1, 2 normal functioning alleles. What's really interesting about the intermediate metabolizers is it's a normal and a decreased function or no function allele, but it's also a high function and a low function allele, which just makes me think that probably the low functional alleles are more indicative of voriconazole concentration if you've got both than the high functioning alleles. And then the poor metabolizers have got 2 essentially non-functioning alleles. So if you've got 2 1717, you've got heaps of active 2C19s, and your voriconazole is just metabolized out of your body incredibly quickly. And if you've got, say, a star 2, 2, you have very low functioning of your 2C19 cytochrome enzymes. And so the voriconazole stays in your system for a lot longer. Okay, I'll just quickly say, we don't really know the exact incidence of these in the population because we haven't tested everyone in the population. So what we know about the prevalence is really dependent on what people have actually measured. We do know the ultra-rapid metabolizers are quite uncommon. They're probably about 2 to 5% of the population. And the normal metabolizers are the majority, up to about 50% of the population. But the intermediates can be up to about 45% of some studies. Of course, there's probably some ethnicity-related variations of this, although not everyone knows what their ethnicity is. And the poor metabolizers are more frequent than the ultra-rapid, somewhere maybe about 30%. Okay, great. And so graphs or it didn't happen. You can see here that the voriconazole trough plasma concentration on the y-axis, you can see the ultra-rapid metabolizer just always at subtherapeutic concentrations because the voriconazole is getting chewed up by their incredibly functional 2C19s. And the poor metabolizers down the other end have those trough concentrations up around 6.5. And then this is just another graph showing sort of the same thing, but essentially that total exposure is also affected. So this is from different studies, the different lines. with a 200 and 400 milligram dose. You can see the 117 is one of the rapid metabolizer at the start there with a low AUC, and 2.2 would be a poor metabolizer, and you can see that it's got a much higher AUC comparative to the other genotypes. So I guess the question is, why incorporate pharmacogenomics into dosing? It maximizes the chance of being the therapeutic range at the first TDM. These two trials here, the first one by Julian Lindsay, who is an Australian pharmacist now over at Fred Hutch, and Alison Boast, who's a pediatric infectious diseases doctor down in Melbourne, just showing that at the moment we're really probably hitting the target range in about 50% of our patients at the first TDM. And for such serious infections, we might want to increase that. The other thing that we are a little bit limited by with voriconazole is we might get a low concentration at the first TDM. We're aware of nonlinear pharmacokinetics, so we make small dose increases to try and get into the range. And if you're a 17-17, you actually need to be making big dose increases or changing the way you're getting the voriconazole with changing frequency as opposed to just making small changes. And if you've got to wait 5 to 7 days for the next TDM, with every dose increase, you've got to wait a week. And how can you sleep? All you want to know is the voriconazole concentration. Eventually, someone will get like a chip you can put in their arm and you can just watch the voriconazole concentration from home. Then life's going to be good. The other thing is CPIC, which actually I haven't put the link in these slides. Apologies for that. But CPIC is the Clinical Pharmacogenomics Implementation Consortium, and they produce heaps of different guidelines for drugs and pharmacogenomic dosing. And at the moment, their recommendation for patients who have ultra rapid or poor metabolizer status is to avoid voriconazole, which is, I think we hope that we'll be able to get to a more nuanced dosing, a safe algorithm where we could still use voriconazole in these patients. But one of the things to think about is this may give us an inclination that this is not going to be a safe drug to use in our patient if they've got a poor metabolizer status, and we're worried that they're going to get toxicity or they're already at risk of periosteitis if we have to give big doses. I guess the big issue here is not only do we not have access to any of the new antifungals, but we also actually don't have readily available access to 2C19 genotypes. And so at the moment in the Australian consensus guidelines, the recommendation is to think about checking a 2C19 status if you've had 2 subtherapeutic voriconazole concentrations despite adequate dose increases. So the other thing I really feel responsible to not get you too G'd up about pharmacogenomic dosing, there's way more goes into, of course, your voriconazole concentration than just the patient's pharmacogenomics. So there's drug interactions. We know that PPIs, which are pretty cool actually, PPIs, because they increase your voriconazole concentrations, but they decrease your voriconazole concentrations through 2 different mechanisms. So it doesn't really matter it might matter less what your genotype 2C19 is if you're also taking a drug that inhibits 2C19, because the outcome of those 2 things is going to be better reflected in your TDM than just thinking about a patient's genotype. There's also, I really listed the most niche drug interactions here. I mean, there's obviously drug interactions with things like tacrolimus that we see all the time, but that's boring. The interesting ones are flucloxacillin. Great work coming out of New South Wales showing at the moment that when you give flucloxacillin, your voriconazole concentrations seem to massively decrease. And the other one that we're seeing in practice that hasn't got a lot of publications yet is starting linezolid on patients on voriconazole, and they seem to have a decrease in their voriconazole concentrations as well. Again, the other thing would be organ function. So again, testing someone's 2C19 status when they've got significant liver disease, you need to sort of marry all that up. And then you need to think as well about how much drug you want to give to get the site of infection for the pathogen you're treating. And the other interesting thing that we're seeing is there's some impact of inflammation on 2C19, where patients with a high CRP seem to have their 2C19 downregulated. Okay, so I'll just go through a couple of studies that have done genotype-based dosing for voriconazole, and then I'll introduce the study that we're about to start. So this is a small study by Patel et al. That was in Blood, the journal Blood, and it looked at giving ultra-rapid metabolizers or rapid metabolizers 300 BD instead of 200 BD, and this was for prophylaxis. It didn't really have very compelling findings. So it did manage to get the ultra rapid and the rapid metabolizers into the therapeutic range with no patients below 1. But actually, it just sort of looks like 200 milligrams BD mightn't be enough for anyone, because a lot of the normal metabolizers and intermediate metabolizers that only got 200 BD were actually quite often below the range. So it was reassuring about giving a higher dose in the ultra rapids and rapids, but I think overall not particularly compelling data. This is a much bigger trial in 263 AML patients, again looking at voriconazole for prophylaxis. And this is it's a gorgeous graph, but the y-axis is the percent of patients who avoided subtherapeutic concentrations. And what they're showing here is really the blue line and the red line, that for the 117, so those rapid metabolizers, when they got 200 BID, they only about 45% avoided a subtherapeutic concentration. When they got 300 BD, that significantly increased to over 80% of people avoided a subtherapeutic concentration. And then this was mostly in children, a pilot study pre-post implementation of voriconazole, genotype-based dosing for voriconazole, again for prophylaxis. These data are very compelling. The genotype-directed, I'm putting the laser on my screen. Yes, Amy, that bit. Not very helpful. Anyway, so the time to target range for all in the pilot study was 29 days. In the genotype-directed dosing study was 6.5 days. I mean, shut the front door. And the dose required for some of the different genotypes was higher or lower. So showing that it can be very useful for both time to concentration, time to concentration in the therapeutic range. And also the last three lines there looking at toxicity were much better with the genotype-directed dosing. And then just finally to say, we probably don't really know what to do yet once we've got the patient's genotype. So this was a physiologically based pharmacokinetic model that suggested for normal metabolizers, you can maybe give the standard dose or give a bigger loading dose. For intermediate metabolizers, you might reduce the daily dose by 50 to 75%. And for rapids, you might increase the dose from 100 to 300%. So still very variable there. And I think the genotype part of this is just one aspect of the patient that we're, giving a voriconazole whole treatment plan to. So how to move this to prime time? Well, we're running a randomized controlled trial really led by Julian Lindsay and Jason Roberts called the Pragmatic Trial. Jason's still here, but it's not super pragmatic. But it is going to be very useful. So essentially the Pragmatic Trial aims to answer if precision care increases the proportion of patients achieving a therapeutic antifungal exposure at day 8 compared to standard care. Standard of care is usual practice, including TDM. Precision care is getting a 2C19 genotype on day 1, using therapeutic drug monitoring and dosing simulation to come up with a really bespoke treatment regimen, and then comparing the therapeutic drug concentrations at day 8. We've got a huge investigator list, and just to say there's been lots of people involved in this, and to give my thanks to all of them. I'll go through that. So we're hoping to get about 100 patients. The primary outcome is the proportion of patients achieving a therapeutic exposure on day 8. So this is a little busy, but essentially we're taking, at the moment, blood samples of the buccal are looking increasingly attractive to get the 2C19 status. They, at the moment, all go down to Melbourne to MyDNA, and we get the 2C19 back within about 72 hours. We are doing some extra TDMs. So we're doing a TDM on day 1 and day 2 just to use within our dosing simulation. And then we do a pre-dose TDM on day 4, adjust the dose on day 5, and check whether they got into the therapeutic range on day This is just what a 2C19 report looks like. This is an example, and you can see this patient's got a star 2, and the reports are quite good. They give you a lot of information about which matches up quite well to what we would say. So they're very easy to interpret. We then have developed, really through Julian and his interactions with the CPIC group, we've then developed a pharmacogenomic-based dosing where based on your metabolizer status, we adjust the dose. And realistically in the trial, what that looks like is once we get our first TDM, looking at a subtherapeutic TDM and then making dose increases based on their genotype status, or looking at their supratherapeutic and making changes based on their metabolizer status, and then putting those into a dosing simulation software to check the dose the concentration we would get at day 8. This is what the dosing simulation software looks like. So this is IDODS. The black line is what the patient's currently experiencing, and the pink line is we can model different doses to see whether we could get them into the trough concentration. So I think this patient was on 200 BD, had a day 5 TDM of had a day 4 TDM of below 1. It was about 1.7, and then we had to give them, the dosing simulation was telling us to give 450 12-hourly to get to a steady state of concentration of 1.7. But we do fiddle around with that to get to, better doses that can achieve the therapeutic trough. And we can also model it so that there's no gap. The problem with voriconazole is if you've just got what your concentration is going to be at steady state, it can take up to a week to get there. So we do also like to model it so that we can see each day how the trough concentration is moving to maximize our chance of getting to a therapeutic trough on day 8. Okay, so in summary, essentially with the significant invasive fungal diseases in patients with hematological malignancy, voriconazole should be effective and not toxic. Many factors affect the voriconazole concentrations being in the desired range, but one of these is the CYP2C19 genotype, which metabolizes voriconazole. Pragmatic is our prospective randomized control trial, which will help answer whether doing pharmacogenomic-based dosing of voriconazole is useful. And you still need to put all of this into the context of the patient when coming up with a dosing and monitoring plan. Thank you.
Thanks so much, Amy.